Dear students, in this module we will talk about the global health risks. In specifically, we will talk about the health risk and the risk factors. We will also cover aspects related to transition of risk with regard to health. Then we will look into the global burden of diseases and the numbers. We will look into the global burden of diseases and injuries. We will look into the global patterns related to health risk. We will also look into the geographical and demographic patterns related to health risk. Then we will talk about the other aspects that are related to health risk. Let us start with the health risk and risk factors. The WHO defined the health risk as a factor that raises the probability of adverse health outcomes. The WHO has identified 5 leading risk factors, and these include the childhood underweight, unsafe sex, alcohol use, unsafe water and sanitation, and high blood pressure. All these 5 factors are the risk factors, are responsible for about 1/4 of all deaths in the world and 1/5 of the DALYs. The reduced exposure to these risk factors would enhance the global life expectancy by about 5 years. The 8 risk factors, namely alcohol use, tobacco use, high blood pressure, high body mass index, high cholesterol, high blood glucose, low fruit and vegetable intake, and low physical activity, account for about 61% of the cardiovascular deaths. These 8 risk factors account for about 3/4 of the heart disease, which is a leading cause of death across the world. Although the major risk factors are usually associated with high income countries, over 84% of the total global burden of disease caused by these risk factors occurs in low income countries and middle income countries. So, the reducing exposure to these 8 risk factors would enhance the global life expectancy in a considerable way. The 9 environmental and behavioral risk factors, together with the 7 infectious causes, are found to be responsible for 45% of the cancer deaths worldwide. For specific cancers, the proportion is higher. To cite an example, tobacco smoking alone causes 71% of the lung cancer deaths worldwide, and tobacco accounted for 18% of the deaths in high income countries. Now let us look at the transition of risk. The health risks are in a transition stage now because the populations are aging, because of the success against infectious diseases. At the same time, the patterns of physical activity and food, alcohol and tobacco consumption are also changing. We are seeing a trend of decline in case of physical activity and also decline in consumption of healthy food, including fruits and vegetables. We are also seeing an increase in trend in consumption of alcohol and tobacco. Low income countries as well as middle income countries are now facing a double burden of increase in chronic non-communicable diseases and also the communicable diseases that are traditionally affecting the poor sections of the society. Understanding the role of these risk factors is vital for developing clear and effective strategies for improving the global health. The health risks are in transition. Understanding the kind of transition in the risk factors is caused by improvements in medical care, which mean that children no longer die from easily curable conditions such as diarrhea. Another aspect that contributed to the transition of risk relates to aging of population, because the non-communicable diseases affect older adults at the highest rates. The public health interventions, including vaccinations and provision of clean water and sanitation, reduce the incidence of infectious diseases. The risks that affect a population also shift over a period of time from those for infectious diseases to that increase the non-communicable diseases. The low-income populations are the most affected by the risks associated with poverty, and these include undernutrition, unsafe sets, unsafe water, poor sanitation and hygiene, and indoor smoke from the solid fuels. These are known as the traditional risks. As the life expectancies increase and major causes of death and disability shift towards chronic and non-communicable, the populations are increasingly facing modern risks due to physical inactivity, overweight and obesity, and other diet related factors, besides the risks associated with tobacco and alcohol consumption. As a result of these, many low and middle income countries are now facing a growing burden from modern risks to health, while the fight with unfinished battle with traditional risks to health is still on. So, they are fighting on both the fronts. On one hand, they are fighting the traditional risks to health, which is unfinished, and now they are also fighting the battle with the modern risks. So, the battle in case of middle income and low income countries is twofold: one with the traditional risks of health and one with the modern risks of health. Impact of these modern risks varies at different levels of socio-economic development. For instance, urban air pollution is a greater risk factor in middle income countries and low income countries than the high income countries, because of the substantial progress made by the high income countries in controlling the risk from urban air pollution through public health policies implemented in an effective manner. Increasing exposure to these emerging risks is not inevitable, and it is amenable to public health intervention. One example could be by enacting strong tobacco control policies. Low income and middle income countries can learn from tobacco control success in the high income countries. By adopting such policies at early stages, they can also avoid higher levels of disease caused by tobacco that is currently found in many of the high income countries. Now, let us look at the figure 1 that indicates the risk transition over a time. The major risks to health are shifting from traditional risks such as inadequate nutrition or unsafe water and sanitation to modern risks such as overweight and obesity. The modern risks may take different trajectories in different countries, and it depends on the risk and the context. The x-axis indicates the time and the y-axis indicates the risk size. At the bottom of the y-axis we have modern risks, and at the top we have the traditional risks, because at the beginning or in the previous decades the traditional risks were at very high level, the risk size was very high in case of the traditional risks and the risk size was very low in case of the modern risk. But as time passes, the risk because of the traditional risk factors has declined substantially and the risk because of the modern risks increased substantially. But in case of factors like urban air quality, road traffic safety and occupational risks, the curve is reverse U, means the risk increased and after some time it started declining. Whereas in case of physical inactivity and overweight and more importantly the tobacco consumption, the risk size increased in a significant way over the time passes. So, this chart indicates the transition in the risk over a period of time from traditional risks to modern risks. The modern risks include physical inactivity, overweight and tobacco. The traditional risks include undernutrition, indoor air pollution, water, sanitation and hygiene. However, many of the high income countries were able to address the issues related to urban air quality, road traffic, safety and occupational risks. As a result of these efforts, the risk size in case of these risk factors has been brought down, whereas in case of tobacco it has not been brought down to a big extent. Now, let us look at the global burden of diseases and injuries. The Global Burden of Disease 2004 update provides a comprehensive assessment of the causes of loss of health in different regions of the world, and this is on the basis of the WHO databases and the information provided by the member states. This consolidated study from WHO made an assessment of comparative importance of diseases and injuries in causing premature death, loss of death and disability in different populations, and these were classified by age, sex and for a range of country groupings by geographic region or country's income or both. Let us now look at the burden of disease. Worldwide, Africa accounts for 9 out of every 10 child deaths due to malaria, and this region also accounts for 9 out of every 10 child deaths due to AIDS, and for about half of the world's child deaths due to diarrhea and pneumonia. In the low income countries, leading cause of death is pneumonia, followed by heart disease, diarrhea, HIV/AIDS and stroke. In the developed or high income countries, the list is topped by heart disease, followed by stroke, lung cancer, pneumonia, asthma or bronchitis. The risk of death by sex indicates that men of 15 to 60 years have relatively higher risk of dying than women in the same age category, irrespective of the region of the world to which they belong. This is primarily because of injuries including violence and conflict, besides the higher levels of heart disease. The difference is most pronounced in the Latin America and the Caribbean, the Middle East and the Eastern Europe. Let us now talk about depression. Depression is a leading cause of years lost due to disability. The burden being 50% higher for females than males. In all income strata, alcohol dependence and problem use is among the 10 leading causes of disability. Let us continue the discussion on global patterns of health risk. More than one-third of the world's death can be attributed to a small number of risk factors. The 24 risk factors given in the WHO's report are primarily responsible for 44% of the global deaths. These 10 leading risk factors account for 33% of the deaths. So, understanding the role of these risk factors is key to developing a clear and effective strategy for improving the global health. 5 leading global risks for mortality in the world include high blood pressure, tobacco use, high blood glucose, physical inactivity, and overweight and obesity. And these 5 leading global risks are responsible for raising the risk of chronic diseases such as heart diseases and cancers. And these 5 leading global risk factors affect countries across all income groups: high income, middle income, and low income group countries. The leading global risks for burden of disease in the world include underweight and unsafe sex, followed by alcohol use and unsafe water, sanitation and hygiene. Alcohol use has a unique geographic and sex pattern. It exerts largest toll on men in Africa and in the middle income countries in the Americas and in some of the high income countries as well. Substantially different disease patterns exist between high income, middle income and low income countries. For the high and middle income countries, most of the important risk factors are those associated with chronic diseases such as heart disease and cancer. Tobacco is one of the leading risks for both the types of countries, and tobacco use accounts for 11% of disease burden and 18% of deaths in high income countries. For the high income countries, alcohol, overweight and blood pressure are also the leading causes of healthy life years lost, each being responsible for about 6 to 7% of the total. On the other hand, in the middle income countries, the risks for chronic diseases also cause largest share of deaths, though the risks such as unsafe sex and unsafe water and sanitation also cause a larger share of burden of disease than in the high income countries. In the low income countries, relatively few risks are responsible for large percentage of higher number of deaths and loss of healthy years. These risks in case of low income countries generally act by increasing incidence of or severity of infectious diseases. The leading risk factor for low income countries is underweight, which represents about 10% of the total disease burden. In combination, childhood underweight, micronutrient deficiencies, maybe iron deficiency, vitamin A deficiency or zinc deficiency, and suboptimal breastfeeding cause about 7% of the deaths and 10% of total disease burden. The combined burden from these nutritional risks is almost equivalent to entire disease and injury burden of high income countries. Now let us look at the demographic patterns. The profile of risk changes considerably by age, and age is an important demographic factor. Some of the risks affect children almost exclusively, and these include underweight, undernutrition, apart from iron deficiency, unsafe water, smoke from household use of solid fuels, and climate change. On the other hand, some of the risk factors affect adolescent health per se. Although the risk behaviors starting in adolescence do have a considerable effect on health at the subsequent ages. For adults, there are considerable differentials depending on the age. Most of the health burden from addictive substances, unsafe sex, lack of contraception, iron deficiency and child sex abuse occurs among the younger adults. Most of the health burden from risk factors for chronic diseases such as cardiovascular disease and cancers occurs at older adult ages. Continuing the discussion on the demographic patterns, men and women are affected about equally from risks associated with diet, environment and unsafe sex. Men are seen to be suffering more than 75% of the burden from addictive substances and most of the burden from occupational risks. On the other hand, women suffer all of the burden from lack of contraception, 80% of the deaths caused by iron deficiency and about 2/3 of the burden caused by child sexual abuse. Now let us look at figure 2 that gives the information about deaths attributed to the 19 leading risk factors by country and income level as on 2004. On the x-axis we have mortality in thousands with a total of 58.8 million, and on the y-axis we have the major risk factors, and then the countries have been divided into 3 categories on the basis of income: high income countries, middle income countries and low income countries. Look at some of the risk factors like iron deficiency, unsafe healthcare injections, zinc deficiency, vitamin A deficiency. These are contributing to mortality only in the case of low income countries. In case of other factors like occupational risks, urban outdoor air pollution, suboptimal breastfeeding, they also affect the mortality in low income countries in a big way and also the middle income countries. Other factors like unsafe sex affects the mortality in a big way in the low income countries and in a moderate way the countries of middle income. In case of the high blood pressure, the effects of this risk factor on mortality are more in middle income countries, relatively less in low income countries and much relatively lower in case of the high income countries. So similar kinds of trends can be seen. One can see the transition from the mortality because of various risk factors as we move from one income category to other income category. Let us look at figure 3 that gives the percentage of disability adjusted life years attributed to the 19 leading risk factors. Here the x-axis gives the percentage of global disability adjusted life years. In case of childhood underweight, the maximum contribution is there in case of the low income category. Same is true for unsafe sex. In case of alcohol use, high blood pressure and tobacco use, contribution of these factors to disability adjusted life years is more in case of middle income countries, followed by low income countries and the high income countries. The vitamin A deficiency contribution to disability adjusted life years is more in case of low income countries and slightly visible impact in case of the middle income countries. Indoor smoke from solid fuels. The contribution is more in case of low income countries and slightly less in case of the middle income countries, and not at all visible in case of high income countries. Let us look at the table 1. It gives the ranking of selected risk factors. The 10 leading risk factors causes of death by income group in 2004. In case of the high income group countries, tobacco use, high blood pressure, overweight and obesity, physical inactivity, high blood glucose, high cholesterol, low fruit and vegetable intake, urban outdoor air pollution, alcohol use and occupational risk are the 10 major risk factors. In case of low income countries, childhood underweight, high blood pressure, unsafe sex, unsafe water, sanitation hygiene, high blood glucose, indoor smoke from solid fuels, tobacco use, physical inactivity, suboptimal breastfeeding and high cholesterol are the leading risk factors causing death. So, the patterns vary from country to country on the basis of the income level of the country. The national income per capita is considered here to classify the countries. Those countries with $825 or less are considered as low income, and the countries with income of $166 are considered as more income countries. The table 2 gives the ranking of selected risk factors, 10 leading risk factors causing the DALY by income groups. The pattern is same as what we have seen in the earlier figure. The table 3 gives the deaths and DALY attributable to 6 risk factors for child and maternal undernutrition and to 6 risks combined. Let us look at figure 4. It gives the major causes of death in children under 5 years old with disease specific contribution of undernutrition. The nutritional deficiencies, other infections account for 12%, malaria 7%, diarrhea 17%, pneumonia 17%, non-communicable diseases account for 7%, prematurity accounts for 11%, severe neonatal infections account for 11%. Let us look at figure 5. This is indicating the attributable DALY rates for selected diet related risk factors. Table 5 gives the deaths and DALY attributable to alcohol, tobacco and illicit drug use and all the 3 risks together. So, let us now summarize about this module. In this module, we looked into the definition of health risk as per WHO, and the definition says that health risk is a factor that raises probability of adverse health outcomes. We also looked into the leading risk factors identified by WHO such as childhood underweight, unsafe sex, alcohol use, unsafe water and sanitation and high blood pressure. We also have seen the contribution of these leading risk factors in terms of mortality and DALY. We also have seen the contribution of the 8 risk factors including alcohol use, tobacco use, high blood pressure, high body mass index, high cholesterol, high blood glucose, low fruit and vegetable intake and physical inactivity that account for about 61% of the cardiovascular deaths. We also have seen the contribution of other risk factors in terms of total global burden. We also have seen the role of environmental and behavioral risks together with the 7 infectious causes which lead to about 45% of the cancer deaths worldwide. We also have seen the kind of transition that is taking place in the health risks. The countries are moving from the traditional risks to modern risks. Over a period of time, the shift is caused by several factors including population related factors, public health interventions, and changes in the lifestyle and overall well-being of the society is affected by these risk factors through morbidity as well as mortality. We also have seen the global burden of diseases and injuries on the basis of the WHO data sets that are available. We have seen the burden of disease in the African region because of malaria, because of AIDS, and because of childhood deaths due to diarrhea and pneumonia. We also have seen the cause of death patterns, particularly that of pneumonia, heart disease, diarrhea and HIV, AIDS and stroke in low income countries, and the disease patterns and cause of death in case of the developed and high income countries. We also have seen the risk of death by sex, and we also observed the global patterns of health risk, because more than 1/3 of the world's deaths are attributed to small number of risk factors. So this module helped us in understanding about various aspects relating to global risk with reference to health. We also have got an understanding about the patterns that are emerging and the transition that is taking place with regard to global health risk. Thank you very much.